with another race or ethnicity. We do analyze these numbers as rates per 100,000 people so that we can make comparisons with other groups across the population and really better understand which groups are disproportionately affected by COVID-19. And while the number of deaths has decreased slightly across all groups, there continues to be significant disproportionality. The death rate among Native Hawaiians and Pacific Islanders is 52 people per 100,000, 52 deaths per 100,000 people. And among African Americans, the death rate is 33 deaths per 100,000 people. For people who identify as Latino and Latinx, the death rate is 32 deaths per 100,000 people. For people who are Asian, the rate of death is 23 deaths per 100,000 people. And for whites, the death rate is 17 deaths per 100,000 people. When you look at this data by community poverty levels, we also see that people who live in areas with high rates of poverty continue to have almost 4 times the rate of death for COVID-19. 56 deaths per 100,000 people. This is compared with communities with very low poverty levels who had a death rate of 15 deaths per 100,000 people. These numbers continue to be very disturbing, and they do require immediate action. As Supervisor Solis noted earlier this week on Tuesday, the Board of Supervisors heard and unanimously carried a motion authored by Supervisors Solis and Kuehl entitled A Just and Equitable Response to the Disparities Illuminated by the COVID-19 Pandemic. I want to extend my deep appreciation for the board's leadership and support in calling out racism as a public health issue, and that this is magnified during the COVID-19 pandemic. Most importantly, racism is a problem that's best addressed through a multi-sector response, like the one that's outlined in the motion, that builds upon the strengths and trusted relationships of many different partners within and beyond government, and it's fueled by a desire to change fundamentally systems and practices that negatively impact people of color and people living in poverty. While these are challenging economic times, my colleagues at the Health Integration Alliance, Dr. Galley and Dr. Sharon, and I fully support the innovation required for the county to eliminate racism and to address to come up with innovative solutions that will actually make a difference. In particular, we're all looking at working together to support local community-based clinics and organizations for their expertise, highly skilled workforce, passion and commitment to serve their communities, and to carry out the very activities that increase access to the services desperately needed to address the disproportionality we see among people who are suffering from COVID-19. This includes COVID-19 testing services, awareness and support of contact tracing activities, direct linkages to in-language, culturally responsive, supportive resources, including food, housing, and economic security, as well as support for those that are being asked to isolate and quarantine as necessary. I want to particularly thank the Advancement Project California for their leadership, and I have immense gratitude to the cross-sector group that has come together representing justice, labor rights, media, philanthropy, and other organizations to address the root cause of the inequities we continue to see that affect our Black and brown residents. There is incredible power in collective thinking and collective action, and I thank everyone again who's been on the front lines protesting and all those working to make sure we have just solutions. Thanks also to the Board of Supervisors and to the CEO for their leadership and support on this most important issue. We do look forward to keeping you up to date on this work, and we're so grateful for everyone who is making a difference and taking a stand against racism and violence. Thank you for using your voices and your actions. I do have an update today as well on the indicators that we're tracking through our recovery journey and the changes that we're seeing over time. Please advance slide 1. And as I mentioned on Wednesday, when we are looking at trends, it is a good idea to look at daily 7-day averages over time. Using a 7-day average prevents the daily ups and downs from skewing the data and shows us a clearer picture, in this case, of our trends among people who have passed away. This first slide shows the average daily deaths since April 5th. And as you can see, we've had a slight peak, and for the last couple of weeks, as I've been reporting, deaths are down. Again, this is nowhere near where we'd like to be, but we're happy that at least the line is now moving in the right direction. So you can see that we're currently seeing average daily deaths declining. On March 8th, our average daily deaths was 46, and as of yesterday, the average daily death was 18 people. Again, our hearts go out to everybody who's experienced a loss. Our next slide, please. This slide shows the average daily deaths by race and ethnicity. And while you can notice that deaths are decreasing across all races and ethnicities, we are still seeing significant inequities that translate to greater rates of death among people of color, as I noted earlier. This slide also shows that deaths among people of color are seeing a less of a decline than deaths among people who are white. Take the next slide, please. This slide shows the average daily deaths by community income level, and again, we're seeing declines across all groups. However, the orange line at the top represents deaths among people living in higher poverty areas and demonstrates the inequities that I mentioned earlier. Next slide. This is just, I want to make sure that we don't forget that although there's a decline, there's enormous inequity and disproportionality. So this shows you just on a table that the mortality rates amongst people of color and people living in communities with fewer resources continues to be significantly higher than those living in communities with very little poverty and those of us who are white. The next slide, please. Like deaths, the average daily number of hospitalizations has also decreased, and it's now somewhat plateaued at about, on average, 1,400 people being hospitalized each day. Next slide, please. And this demonstrates that our capacity in the intensive care units and our supply of ventilators has remained relatively stable over time. Next slide. Our supply of personal protective equipment is meeting the goals across the board, with over 80% of hospitals having at least a 15-day supply of N95 masks, other masks, eye protection, and face shields. 79% of hospitals have a 15-day supply of gloves, and 66% of hospitals have a 15-day supply of gowns. I want to thank all of our hospital partners and EMS for making sure that we continue to maintain the kind of personal protective equipment that every single healthcare worker needs in order to be able to do their job with as much safety as possible. The next slide. This slide shows the average daily reported number of diagnostic tests for COVID-19. And I want to again thank the Department of Health Services. We've exceeded our goal of testing being able to test 15,000 people a day. As a matter of fact, at the peak, we were testing over 20,000 people a day. And I do want to note that we've seen a decrease in testing over the last 2 weeks, and this is likely reflective of the closure of some testing sites to accommodate the protests. The next slide. Finally, we continue to meet our goal for the percentage of COVID-19 cases that have a follow-up investigation started within 1 day of the Department of Public Health receiving information on the positive cases. Over the last week, this number has ranged between 98% and 100%. We're going to continue to watch these indicators closely to understand how reopenings are affecting the spread of COVID-19 and our capacity to treat people who may become seriously ill. Our day-to-day actions have a huge impact on our progress and on our recovery journey. So please continue to use the tools we have at hand to slow the spread. Practice physical distancing and wear cloth face coverings when you're out and around others. I want to note that the data we're presenting today, again, reflects actions people were taking 3 weeks ago. So please, 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 as we're reopening more places and more spaces, it becomes extraordinarily important for people to practice that distancing 6 feet or more, and to always have your cloth face covering on when you're going to be around other people. And in closing, as we mentioned on Wednesday, we issued a modified health officer order yesterday that permits additional sectors to reopen as early as today once they implement the required protocols for infection control and distancing. These businesses include gyms and fitness facilities, pro league arenas without live audiences, day camps, museums, galleries, zoos, and aquariums, campgrounds, RV parks, and outdoor recreation. This includes swimming pools, music, film, and television production, and hotels for leisure travel. Before a business can reopen, they must implement the protocols. These are not recommendations, these are requirements. And the modified health officer order and the protocols are available on our website, publichealth.lacounty.gov. We ask that businesses take the time they need to fully implement the directives before they open their doors to employees, customers, and visitors, and that they provide a copy of their implementation plan to all of their employees. And as this weekend begins, please remember that a safe recovery journey relies on every single one of us, businesses and residents. We need to continue to work together and keep each other as safe as possible. With that, we're ready for questions.
And ladies and gentlemen, if you'd like to ask a question, please press 1 then 0 on your telephone keypad. You may withdraw your question at any time by repeating the 1-0 command. If you're using a speakerphone, please pick up the handset before pressing the numbers. Once again, if you have a question, please press 1 then 0 at this time. And just a moment, please, for our first question. And we first turn to the line of Alex Wigglesworth with the LA Times. Please go ahead.
Hi, thank you. So I just wanted to confirm, are you noticing a rise in hospitalizations related to COVID-19? Because there have been anecdotal reports that hospitalizations are rising at places like County USC, but I believe you just said that they've been roughly stable.
Yeah, it's a really good question. For the system as a whole, no, we've actually seen a decrease in sort of the daily census. I do want to note a couple of things. One is, again, the disproportionality that we see in in particular, who's passing away, also affects who's hospitalized. And those hospitals that are serving our Black and brown communities are likely to have higher rates of hospitalizations as a reflection of who, in fact, is more likely to be very sick with COVID-19. But yes, in general, across the entire system, we have had a definite decrease in the daily hospital census associated for COVID-19. I also want to note that we would expect an uptick, a slight uptick, because most hospitals are now testing every person that comes in to be admitted into the hospital, even if it's for like a gallbladder surgery, they're getting tested for COVID-19. And because we know there's asymptomatic people without any symptoms who can test positive, we would imagine that as the hospitals continue with this more routine testing of everybody that's going to be residing in their hospital, that they too will pick up more cases of COVID-19. We'll take the next question.
And next we turn to the line of Brenda Gazar with Southern California News Group. Please go ahead.
Hi, thank you. My first question has to do with PPE at nursing homes. You mentioned that hospitals had enough PPE. Do you have a sense of whether nursing homes or skilled nursing facilities have enough PPE? Is that something that you're actively tracking? And what's the verdict on that? And my second question has to do with masking. I know there was a report in Germany in late January that confirmed that there was asymptomatic transmission, that the virus could do that. But yet the county, I believe in April 24th, put out the order that all healthcare workers in skilled nursing facilities needed to wear masks. So why do you think there was such a delay in making sure that everyone was wearing a mask in these facilities? Thank you.
Yeah, thanks a lot. Let me just start with the PPE in nursing homes. We have a separate team at the Department of Public Health that really works to make sure that we can be helpful for the nursing homes and to secure the supply chains that are needed so that all of the employees and, in fact, now residents have the kind of PPE that's needed for those places to really operate as safely as possible. I would say that, we make sure that nobody runs out of PPE, but in terms of being able to keep in stock sort of 14-day supplies, the numbers are actually lower for the nursing homes. We're working really hard to make sure that we've got a stockpile that's appropriate for all of the nursing homes. Right now, what we've done our best job on is making sure that no one's running out, but we could do better, I think, as a whole, working with the state and our federal partners on making sure that they have an adequate stockpile of PPE. And in terms of the last question, I want to note that the studies were very mixed at first, and as a matter of fact, they're still mixed studies on asymptomatic spread. As soon as it became apparent to us in the nursing homes with data that actually demonstrated asymptomatic spread, we moved in very quickly to change our guidance. But I want to note that even to this day, there are conflicting research studies on how much asymptomatic spread there is. You saw the WHO had to walk back their recommendation just earlier this week, saying that there was no asymptomatic spread. I stood here and actually said at that point that I am certain there's asymptomatic spread because we have our own data now here in the county that actually demonstrates asymptomatic spread. But thanks for that question. We'll take the next question.
And next we turn to the line of Josh Haskell with ABC7. Please go ahead.
Hey, Dr. Ferrer. Wondering if you've been in contact with the new interim director of the Orange County Healthcare Agency, and what is your reaction to his decision to go from masks being required in the county to now being strongly recommended?
Yeah. Thanks. I haven't had an opportunity to welcome the new health officer there. I want to give my thanks to the previous health officer, who we worked with very closely, and I know that we'll have a very close working relationship, as we do with all of the Southern California directors and county health officers. These are really hard jobs. Decisions are very specific to each county, and I understand that. We, of course, we're the largest county. We have a lot at stake in our reopening. We also have the highest numbers of everything across the state. And masking is a really important part of our recovery. So we have, as you noted, we have required that everyone, when they're around other people, needs to wear a cloth face covering. And we look forward to working with all of our colleagues across Southern California in making sure we share with each other what's working and best practices. So thank you. We'll take the next question.
And next we turn to the line of Patrick Healy with NBC4. Please go ahead.
Thank you very much. Doctor, I'm curious, if our test rate rises above 8%, do we lose our variance? Is that automatic, or do we voluntarily surrender it at that point? And if your colleague, Dr. Galley, is with you today, I'm wondering if she could elaborate more on the modeling revelations from Wednesday. How much over 1 is the R0 number? How many more cases do we expect in the coming weeks? And further detail on how ICU is going to deal with its capacity being squeezed. Thank you.
Yeah, thanks a lot. No, I don't actually think there's a process for losing your variance. I do think, again, we work really closely with the state, and they help us monitor our metrics as well as the state's metrics that they have for all of the counties to make sure that we're not, moving into an area that's troubling. As I noted earlier, the state did ask us to take a hard look at the fact that our case counts are high, but we've been working with them and we've shown them our data that indicates that's really, at this point, a result of a lot of testing. And you're absolutely right. Should we see an increase in positivity rates, which we're likely to do. I mean, that's entirely possible given all of the reopenings that are happening and the ability for people to actually mingle more with each other in workplaces and in other places. If we see that increase, we're going to be needing to watch that very carefully, and particularly to watch how it affects what's going on in our hospital care system. Again, we look at this data every single day. We track it very carefully. If you start seeing a lot of increases in that positivity rate, that could indicate more community transmission. We'd have to make sure we really understood what was driving that increase in that rate. Sometimes it's just a reflection that you've done a lot more testing in one particular sector. Other times it's a reflection of exactly what we would worry about, a lot more community transmission. So we're going to watch that very carefully over the next few weeks. We're going to make sure we don't put ourselves in any situation where we're creating jeopardy for all of the residents across the county. And I'll turn it over to Dr. Galley. She is here.
Hi, thanks for the question. So with respect to the R, the effective transmission rate, the model projects that it's running just slightly above 1, I would say around 1.2 or so, and this is projected out 4 weeks. So the data that's on the slides included on the DHS website show a projection out to July 8th, that week, the first or second week in July, showing it constant and stable at around that 1.2 rate. With respect to your other questions on ICU bed capacity, it's because of that slight upward trend in the R, where previously it was under 1 and now it's projected at being slightly over 1. Those small differences can make a large difference over time in the use of beds. Just as a reminder, the way the model works is that it projects R not based on the overall case positivity rate in the county or the numbers that are testing positive, because that's dependent on things like how many people are seeking tests or rates among asymptomatic individuals who would never need hospital care. Rather, the model looks at only those cases that end up requiring hospital level care. So we're really tailoring those projections to what the demand is within the hospital setting, which is where our focus is. So with those numbers, the model projects that over the subsequent 2 to 4 weeks, there runs a degree of uncertainty that the current number of available ICU beds would be insufficient to accommodate the anticipated demand for COVID patients. This is something that we are working on with our EMS agency, which is part of DHS. They've had conference calls and discussions on an ongoing basis with all of the private hospitals as well as with the DHS public hospitals. And hospitals are doing, just as they always have throughout the pandemic, a variety of things to accommodate this potential increase in patients. First, there's the ability to reduce the census in the ICUs by curbing elective procedures and elective surgeries if that can be safely done so. They can make room for additional patients by increasing their staffing, shifting more toward team-based staffing models, bringing on new staff through various mechanisms. And then they can also turn physical space outside of the ICUs where needed, including post-anesthesia care units, emergency departments, other physical settings that may not be needed for the care of other patients so that it can accommodate ICU. When we look at those anticipated number of ICU beds, there's not a need to bring on additional physical capacity. The physical hospitals are generally able to accommodate the surge in patients, and that's the best and safest place for patients to be taken care of given the overall infrastructure that's located within the hospital settings. So our goal is to make sure that hospitals can accommodate and take care of the patients within their physical buildings by having them have the appropriate amount of PPE and supplies, ventilators, and staff. And I would just remind you all that the model continues to show that we have more than enough ventilators to take care of those patients that anticipate a need for mechanical ventilation. We'll take the next question.
And next we turn to the line of Dave Lopez with Channel 2 News. Please go ahead.
Yes, good afternoon. Doctor, obviously you wouldn't be moving this quickly if you didn't think that the data was there and the numbers seem to be pretty impressive. But still there's a lot of fear from people that behind in their mind they're saying, we're going too fast, we're going too fast. How do you assure them that it is okay to go out and test the waters, if you will? And my second point on the question of masks, I wonder if you can give us an explanation on this. Japan, where just about everywhere is a mask, the death rate is 920 compared to the U.S. 116,000, and the deaths per million in the United States is 1 million per 351 per 1 million. Japan, it's only 7. Is it too simple to say that it's the mask that is the difference?
Yeah, thanks a lot, Dave, for both questions. Maybe I'll start with the masking question. We had a lot to learn around the power of masking, and we do think that the masks make a huge difference. There's more than enough evidence to date now that shows that masking up with cloth face coverings does reduce the rate of transmission. And I think it is partly what may account for the lower numbers in Japan. I think there's a lot of other things that contributed to Japan's rates, and I'd be happy to talk at length at another time about sort of some of the differences in how a pandemic is handled in some countries versus others, because I think there are many different strategies that can be used. We've used some successfully here. There are others that we haven't really employed as much of, sort of the contact tracing side of the house, all of that technology that really is able to track people's movements, does a much quicker job of identifying people who have been in contact with others who are now positive for COVID-19. And we're not really using that type of technology here across the country. And it's something that, we need to look at again, make sure it works for us and for our communities. But I think there are other places where there are differences that may help account for some of the differences we're seeing in the mortality rates. And in terms of the broad question about, people being nervous about going out, people still feeling like maybe we're moving too fast, I want to first note a couple of things. One is, particularly for people with underlying health conditions and for people who are older, we do not recommend that you go out and that you partake in a lot of different activities. We've recommended both to employers and to residents that you are at much higher risk if you're in this group, and it is best to stay home as much as possible. So I want to note that while there is a lot of ability for people to actually go and do some things differently than we did a month ago, everyone should really assess their risk for having serious illness and make decisions accordingly, and please work with your employers as well. I do also want to note that for people who are not comfortable with some of the sectors that are reopening as a customer or as a visitor, we urge you not to do activities that are beyond your comfort zone. And I know that there's a lot of variability on the kind of risk that people want to assume for themselves and for their loved ones. I also know there's a lot of variability in the conditions in which we're all living our lives. For those of us who are living with people who are more vulnerable, we might make very different decisions about what we want to do and what activities we want to engage in than other people who don't have that same family configuration. I do also want to note that a successful recovery journey for LA County depends in particular on those sectors that reopen to actually adhere to our protocols. If there is not adherence to the protocols, if we are not taking the basic steps to protect workers and then to protect customers and visitors, this will be way more risky than it needs to be. And we'll take the next question.
And next we turn to the line of Jim Roop with Westwood One News. Please go ahead.
Thank you very much. Good afternoon, Doctor. The World Health Organization today said that, and it posted some guidance on this too, that for women who test positive for COVID-19 are encouraged to continue to initiate and continue to breastfeed, saying that they've not been able to locate or there's no indication of live virus in breast milk. And even if there was a risk, the reward or the benefit of the breast milk would far outweigh the risk. I was just wondering if you had any evidence or if science that you has would counter that or support that, or what's your thoughts on women testing positive with COVID-19 still breastfeeding?
Yeah, I so appreciate that the WHO looked at this issue and is publishing some guidance. Our team is also looking at it. We're also talking to the CDC about any additional studies that really support what the WHO issued today. It is very important that women who are able to can breastfeed, and I think we need to resolve the issue very quickly in terms of the guidance we're issuing. So we're anxious to look at what the WHO issued today. We're also anxious to look at all the research publications, and then we'll work with our federal and state partners to tailor that guidance to experiences that people have today. But I want to note in general, the Public Health Department, as all public health departments, stand firmly behind the importance of breastfeeding where it's possible. So we'll take a look at this and we'll come back and either mirror the guidance or issue something that's slightly different. We have time for one more question.
And our final question comes from the line of Brittany Meha with the LA Times. Please go ahead.
Hi, good afternoon. This question is for Director Ferrer and Supervisor Barger. I was wondering, regarding testing, are you satisfied with the over week-long delay in testing that took place at Norwalk Skilled Nursing and Wellness Center? There was at least 42 residents and 32 employees who tested positive, and at least 6 who died.
Yeah, thanks for that question. Supervisor Barger is not here today. I'll take my best stab at it, but we're also happy to talk with you offline with more detail. We're always saddened when there's deaths that are happening at our nursing homes, and we certainly have a lot of evidence from all the testing that has happened that once you test in a nursing home setting, you're able to identify a lot of sort of asymptomatic cases, which really means that testing is it's a very, very important tool, and we have to be able to use it, and we have to move fairly quickly. I do know that sometimes the logistics, it seems very simple to put the testing in place, and sometimes even our team has been frustrated by barriers that crop up around the logistics, and some of that is really just working with the fact that there are 3 shifts at the nursing homes and making sure that we can manage to test all of the employees. Some of that is working with the administration to put in place protocols. Some of it is staffing issues. So I don't think it's good when there are delays at all, and I'm not apologizing for delays. I don't have the particulars on what were the factors that contributed to delays here. I know that our team is working really hard, almost around the clock, to make sure that we don't continue to see delays, especially unnecessary delays in testing at the skilled nursing facilities. Thank you, and now we'll move to remarks in Spanish.
Buenas tardes. Para actualizarlos, nos da tristeza informar que 20 personas Nos da tristeza informarles que 20 personas adicionales han fallecido por causas de COVID-19. Esto eleva el número total de fallecimientos a 2,832. El 93% de las personas que fallecieron por causas de COVID-19 tenían condiciones delicadas de salud. Este número se ha mantenido constante durante la pandemia. Hoy estamos reportando 1,633 casos nuevos. Esto eleva el número total de personas que dieron positivo por COVID-19 en el condado de Los Ángeles a 70,476. Estamos reportando también 488 casos confirmados entre personas sin hogar. 7,250 personas que dieron positivo para COVID-19 fueron hospitalizadas en algún momento durante su enfermedad, cual representa el 10%